All righty, and good afternoon. Thank you for the introduction, and thank you for inviting me. This is actually one of the more interesting topics and patients that we see in the clinic. No disclosures here. So I wanted to start off by first making sure that we're all on the same page with how we actually define Alzheimer's disease in this day and age. We'll review and touch briefly on the more common presentation and then identify the variants that we're talking about mostly here today. So, what is actually Alzheimer's disease? And I apologize to my patients in clinic because we've actually changed the diagnosis over time. Back in 1984, the first criteria came out, which basically said if you had a dementia syndrome and you've ruled out stroke and Parkinson's disease and hydrocephalus, you probably have Alzheimer's disease. In 2011, they added the newer CSF biomarkers to have more confidence that we're actually dealing with Alzheimer type pathology. In 2018, if you recall the term ATN, standing for the amyloid, tau, and neurodegeneration, we started to define Alzheimer's disease by biological evidence, which then brings us to the most recent criteria in 2024. So it's now defined as a biological process. It begins with the appearance of Alzheimer's disease, neuropathological changes, and then progresses later on to the appearance of clinical symptoms. So basically, at this point in time, if you have biomarker presence for Alzheimer's disease, you can be diagnosed with Alzheimer's disease. The core one biomarkers that you see in the red, those are the ones that we're using most often and ones that you're probably most familiar with, the amyloid PET scans, CSF, A beta, and tau. And you may be aware there's now even serum biomarkers that can be used. So that is defining Alzheimer's disease from a biological biomarker standpoint. Where they are clinically, this is the staging scheme that they have that we all use now. You can actually have stage 0, which means that you don't have the biomarkers yet, but you actually have genetic mutation that will basically indicate that you will develop Alzheimer's disease. Stage 1 are asymptomatic patients that have biomarker positivity. Stage 2, again, they still have biomarker positivity. Patients are starting to notice some changes, but they're still overall pretty much normal with their cognitive functioning. Stage 3 should be relatively familiar. That's what we've always been diagnosing as mild cognitive impairment. And then 4, 5, and 6 stages are describing dementias in mild, moderate, severe stages. So the most common variant that we see, the most common presentation of Alzheimer's disease is the amnestic variant. They're coming in with complaints of memory loss, and that's what a majority of the patients come in when they're having cognitive complaints. They complain about memory loss or forgetfulness. The family members or informants are going to be saying that the patient, they repeat themselves a lot. They forget a lot of details of conversations or prior or recent events. They can be misplacing items. Other cognitive domains outside of memory can be involved either at the same time or usually later in the disease course. Kind of depends on when you see them when they present to you. As with all the other, every time you see a patient coming in with complaints about memory, you ought to keep a broad differential, ruling out other medical conditions, psychiatric conditions, and looking out for signs of other neurodegenerative diseases. That then leads us to talking about the non-amnestic variants, and these are the variants that I'll be focusing on here today, those presentations that don't necessarily involve memory. As a whole, again, they are primarily defined by the other cognitive domain that's most impaired at onset. And a lot of times you have to really probe the history from the patients or the informants, asking them what was the initial symptom that you guys noticed to be a change. All of these are still being diagnosed as Alzheimer's disease by the presence of biomarkers. When you're looking at those biomarkers, if you're looking at the amyloid PET scan results, they all pretty much have a typical, the similar kind of pattern of amyloid PET distribution. Now, what can be different is the abnormalities seen on FDG PET and the tau PET. Those tend to be abnormal in the region that you expect to be involved. If it's more of executive dysfunction, you see more frontal lobe involvement. If there's more visual issues, they'll be more in the posterior areas. Overall, they can have less hippocampal atrophy since there's less memory involvement. These non-amnestic variants do tend to occur in patients that are presenting at younger age. And because of that, and because they're a little bit atypical, they're not complaining about memory loss. Diagnoses can be delayed or at times missed. They can have more of an aggressive course. But as you're evaluating these patients, similar to patients that come in complaining about troubles with memory, you ought to keep a broad differential when considering what else could be going on. And we can cover some of these here next. Let's talk about the language variant of Alzheimer's disease. And so, broadly speaking, when a patient complains about progressive language disorder, that usually falls under the realm of what we would call primary progressive aphasia. The diagnostic criteria for this syndrome from back in 2011 defines it when you have a syndrome where language difficulties are the most prominent feature, and that's what's causing the most impairment. It's not really PPA or primary progressive aphasia when you have other neurological diseases or psychiatric diseases that could be playing a role, or when other cognitive domains are more prominently affected. Now, there are 3 different variants of PPAs. The one that we think of most associated with Alzheimer's disease is what we call the logopenic variant, PPA. They primarily have troubles finding words or word retrieval difficulties when speaking or naming objects, and they have sentence and phrase repetition errors. They ought to have at least 3 of the next features here, either making word sound errors, phonologic errors when speaking. They should have relatively spared word knowledge, object knowledge. Their motor speech is intact, and they don't have a grammatism. So what does that mean? Well, when you're encountering a patient that has the language variant of Alzheimer's disease, their main complaint is going to be word finding difficulties. They have this tip of the tongue phenomenon. It's right there. I just can't get the words out, right? When asking more about that, family members may say, yeah, they kind of keep dancing around the actual word. Circumlocution is what we would call that. They may describe the object, but not actually use the exact name for that thing, that doohickey, that, you know what I'm talking about? I want to flip the channels. Tell me that thing, right? A lot of that word substitution. They're still relatively fluent, but they can have a lot of pauses when they're trying to find those words. And sometimes those words, when they are speaking, may not sound right. How you examine those patients? Well, you listen to how they speak, and you can try to pick up on these errors. You may find that, you may be talking to them for a good 5-10 minutes. And one interesting thing, you may find that they haven't really said much of substance. They can still be quite fluent, quite pleasant, but they really haven't told you a lot of details about what's going on. You can certainly test them with confrontational naming, ask them to name objects or name pictures that you may have. You can ask them and make sure that they still know what those objects or what those words are. They should still be able to know what and recognize what you're showing them. They will just have a hard time naming it. And then don't forget to check their repetition. And so it's nice when you can recall those sentences on the Montreal Cognitive Assessment, the MoCA test. You may scratch your head and say, why am I asking them to repeat these sentences? Well, this is kind of why. You can have them, this is from one of the other versions than version 1. So if you can say to yourself, if I told you, repeat the sentence, the caring grandmother sent groceries over a week ago. You all should be able to repeat that sentence pretty easily, right? The patients that have the logopenic variant or the language variant of Alzheimer's disease, they may say something like, the grandmother sent food over. They won't be able to say that whole sentence. And if it gets bad enough, they'll just tell you, yeah, I can't repeat that. It's actually kind of interesting. So Keep that in mind, but you also have to keep in mind there are other variants of primary progressive aphasia. The first one I'll cover, the non-fluent agrammatic. Well, they're either agrammatic, meaning that their sentence structure is really broken down. They're speaking quite simplistically, or they can have what they call apraxia of speech, where their speech is quite a bit more effortful, halting speech. They can distort word sounds. They can have a hard time interpreting syntactically complex sentences. Best example, the lion was eaten by the tiger. And you can ask them, which animal is still alive? A more simplistic structure of a sentence would say, lion eats tiger. So they would think, well, then the tiger's dead, the lion's still alive. But this is the sentence structure is a little bit more complex, and they may misinterpret that. Again, you can ask them if they can recognize words and objects. So there ought to be a variant that doesn't recognize words or objects, and that's the semantic variant of primary progressive aphasia, where they would have word finding difficulties, right? They'll have a hard time naming that object, but that's because they don't know what that object is anymore. They don't know what that picture represents. And you can test that by actually showing them objects. The one that I like to use, if you have this around in clinic, you have a stapler remover. You know what those look like? The patients, they can pick it up, they can squeeze it, and they know how to use it, but they don't know what to use it for. They can't describe. Had one patient where she started pretending like she was trying to cut her nails with it. She didn't recognize that was to remove staples. They can have what they call surface dyslexia, and how you can test for that. These are phonetically irregular words in the English language. Hopefully, you all can pronounce those correctly. But if you have the patient try to read these words and they say colonel, blued, yacht, pint's a good one. Then you can get a sense that they don't recognize what these words anymore, and so they're trying to pronounce them phonetically. They should have relatively spared repetition and spared speech production. So while you have to keep all of these in mind is because these different primary progressive aphasias have particular associations with the various pathologies. Again, the logopenic variant has a lot more Alzheimer's disease pathologies causing it, although you can certainly test them, and if it's negative, yeah, you have to think about the other pathologies, either TDP-43 or tau causing that syndrome. The other two, the semantic variant, most oftentimes is due to TDP-43 pathology, and then the non-fluence is a mixture of tau pathology or the TDP-43. But again, you can see there is a small representation of Alzheimer's disease that could be causing those syndromes. But most of the time, we're thinking the logopenic variant. All right, let's switch over and talk about the visual variant of Alzheimer's disease. That syndrome, if you're not familiar, it should be you should be thinking about posterior cortical atrophy. And there are diagnostic criteria for this syndrome. Basically saying that there is, again, prominent but early disturbances of visual cognitive abilities or other posterior cognitive function. And I'll go over that here in a little bit. The other domains are relatively spared. This is more or less a clinical radiographic kind of syndrome. So you should also be looking for either atrophy or hypometabolism in the posterior area of the brain, occipital parietal or occipital temporal regions. So this is a nice long list of all the different PCA cognitive features. We often focus on space perception deficits, people who have troubles judging speed or distance or figuring out how things fit together. A lot of these other ones can be kind of hard to memorize all on their own, but I'll give you a hint here. If you can remember these two syndromes, if you remember, Bolin syndrome has a constellation of simultagnosia, ocular motor apraxia, and optic ataxia. And then you have Gerstmann syndrome, where you have left-right disorientation, acalculia, agraphia, and finger agnosia. And so if you're seeing elements of that, you can be quite suspicious that they can meet criteria for posterior cortical atrophy. And so when we see that in patients and in clinic, we often are concerned that they may have this visual variant of Alzheimer's disease. What they're going to come in with in the clinic is complaining about vision problems. Now, one big hint is that if you get a referral from an ophthalmologist or an optometrist, coming to see you because they're having vision problems, but their visual acuity is fine, you have to start thinking about, are you dealing with this posterior cortical atrophy? Patients themselves will complain about having trouble seeing. They may describe having some clumsiness, troubles with navigating. You can ask more about reading difficulties. They can certainly have troubles reading, going from one line to the next. They'll lose their place, and then what they're reading doesn't really make sense. They may have troubles, like I said, putting things together. Ask about driving. Are they able to maintain lane position? Are they hitting objects? You can ask if they're having a hard time finding things that are right in front of them. I usually give the example trying to find that TV remote on this coffee table. They have to look all over that coffee table for that remote because it's not really just popping out at them when they are looking for it. So on exam, how you can test for visual spatial difficulties, you can have them copy figures, like you should be familiar with the cube or the intersecting pentagons. Navon figures is one way to test for simultagnosia. Hopefully you can see the figures here where you have this big E made out of smaller A's. Now, a patient that has posterior cortical atrophy, what they would like to describe is, or tell you, all they see are A's. They see an A, they see another A. And I usually go through the process of asking them, do you see any other letter there? Do you see a larger letter there? Do the A's make another letter? And going through that, they still won't be able to pick out that there's an E there. I like the Poperoid or Gantt figures, basically overlapping line drawings. And hopefully you all can pick out the different figures there, the umbrella, the saw, the pear, the cup. But patients with posterior cortical atrophy can't really pick out those objects. They may focus on smaller pieces, and they may see ice cream scoop somewhere in the middle, a little sausage hanging off on the side there, and the teeth of the saw, they may interpret that to be stairs. So that's actually kind of interesting. And then, yeah, if you don't really have any of these, if you don't have pencil or paper, what you can try to do is interlocking fingers. And so you can try to have them, you can do this in front of them and see if they can pantomime and recreate this using their own hands to see if they can do that. That would tell you that, yeah, their visual spatial abilities are relatively intact, assuming that they, again, they have intact motor functioning otherwise. If they can't do that, you can suspect that they do have some visual spatial difficulties. So do keep in mind, though, that there are other causes of posterior cortical atrophy. I've encountered several patients with Lewy body disease, and so and this is a common presentation for those folks having a lot more visual spatial difficulties at onset. I remember a patient that had basically the syndrome of posterior cortical atrophy, got biomarkers for her, was positive for Alzheimer's disease. But then a few months later, and within a year, she also started developing visual hallucinations and Parkinsonism and dream enactment behavior. So she likely had dual pathology of Lewy body disease and Alzheimer's disease. Keep in mind also cortical basal syndrome and CJD as well can be associated with having a presentation of posterior cortical atrophy. The last two syndromes here that I'm going to cover, the first one, these have been recognized, as it were, but not the clinical syndrome has not been fully defined as well. The dysexecutive, these are a proposed like research diagnostic criteria for this progressive dysexecutive syndrome. And so while they may not have necessarily that episodic memory impairment, they would have progressive declines in executive functioning, working memory, cognitive flexibility, and inhibition. And they should have a lack of predominant behavioral features, and they would want to exclude a history of either sudden onset or other medical conditions that could cause this. How these patients would present, well, they'll still complain about memory problems. A lot of patients, they just come in and complain about memory problems, but what their troubles are perhaps would be more so due to troubles with planning, organization, multitasking, handling multi-step processes. They complain about having more troubles following and playing board games, following directions or recipes, troubles finishing projects or completing projects at home or at work. On examination, you can test more of that executive functioning, asking about similarities of objects. How are a banana and orange are alike? How is a train and bicycle alike? You can ask them to define proverbs. You can try them, have them perform the Luria motor sequence, that fist, edge, and palm task. And you also can try go, no go tasks. You do want to try to exclude other confounding factors like primary psychiatric disorders, cerebral vascular disease, and other medical conditions. The last one I'll talk about is the behavioral variant Alzheimer's disease. Now, the research criteria for this would include having at least two behavioral changes, behavioral disinhibition, apathy or inertia, loss of sympathy or empathy, having more repetitive, perseverative behaviors, and then hyperorality or dietary changes. They would also include the need for impaired executive or episodic memory. And again, not caused by other neurologic or psychiatric conditions. Now, this should all look relatively familiar because this is actually just a modification of the diagnostic criteria for behavioral variant FTD. And so how can you determine the difference between the two? It can be quite challenging. For the research criteria, they would say for considering possible behavioral variant Alzheimer's disease, yeah, you ought to have biomarkers again for Alzheimer's disease in this clinical syndrome. But to be really more certain that this is due to Alzheimer's disease pathology, you ought to get a tau PET, which unfortunately we're not able to have available for clinical use at this point in time. That's why it's pretty much a research criteria. Certainly, if you had autopsy or biopsy data for that, or you know that they have a genetic mutation that would cause Alzheimer's disease, you can be more certain that the Alzheimer's pathology is causing the syndrome. So this would be quite similar to patients with behavioral variant FTD. The complaints would be essentially this is the same person that we all know. They have personality changes, odd behaviors. They have a lack of motivation to do things. You can ask about inappropriate behaviors in public, diminished responses to others, the emotional connection. Ask about compulsive behaviors or particular food preferences. Those are actually less common in behavioral variant Alzheimer's disease. And so this is a nice graph showing the prevalence of these different features, comparing behavioral variant FTD on the top versus behavioral variant Alzheimer's disease on the bottom. And so those that have their syndrome due primarily to Alzheimer's disease have less the compulsiveness and hyperorality. What is more common in those that have Alzheimer's disease is more agitation, more psychosis, and worse cognitive functioning, memory or other domains. So those are the main variants of Alzheimer's disease that we encounter in clinic. Treatment overall remains relatively similar to what we have for those that have the typical amnestic Alzheimer's disease. We can use cholinesterase inhibitors. We can use memantine. do certainly consider psychiatric medications to help the behavioral symptoms, think about therapies, make sure that the caregivers that are helping out the patients have the resources that they need. And if you need to have social work involved. Now, I bet one big question is, what about these newer anti-amyloid therapies that are available and approved for patients that have Alzheimer's disease and a mild cognitive impairment or mild dementia stage? There are two published appropriate use recommendations that I use and I refer to quite often. And they would say that these variants of Alzheimer's disease, they can be included for being treated with these monoclonal antibodies. They do specifically mention in the one by Gil Rabinovici for posterior cortical atrophy, the logopenic variant, and the dysexecutive. I think they left out intentionally the behavioral variant Alzheimer's disease because that is going to be a lot harder to distinguish clinically from behavioral variant FTD. I will also make mention that in the clinical trials that were run to determine the effectiveness of these anti-amyloid therapies, they primarily enrolled patients that had the amnestic presentation. They didn't exclude those patients that had these other variants, so long as they also had memory impairment in the initial screening assessment. So in conclusion, when we're thinking about these variants of Alzheimer's disease, they are primarily defined by having early and prominent non-amnestic cognitive impairment with, again, biomarker evidence that, yes, they do have Alzheimer's disease. The language variant of Alzheimer's disease, which we would call the logopenic variant of primary progressive aphasia, they can be differentiated from those other PPA variants. Again, if you can remember, they have troubles with finding words. They still know what those words are. They know what the object is. They just can't find the words. And they also have impaired repetition. So those can be differentiated from the non-fluence and the semantic variants of primary progressive aphasia. When you're having a patient that is having a lot of complaints about visuospatial difficulties, think about the posterior cortical atrophy syndrome. A lot of them do have Alzheimer's disease as the underlying pathology, but look for those signs of other diseases like Lewy body disease or cortical basal syndrome. The executive and behavioral variant Alzheimer's disease are becoming increasingly recognized. But as you're encountering these patients, do keep in mind that the treatment options are more or less similar to those that have the amnestic variant of Alzheimer's disease. So with that, I'd like to thank the organizers for the summit and my colleagues over in our division.